floor is yours.
Thank you very much, chairpersons. And what I'd like to try to tell you in as short a time as possible is, can we replicate the advantages we've heard about in prone positioning with chest wall compression? Now, I think we understand that increasing abdominal pressure, however we do it, will reduce the respiratory system volume. A normal individual compared with a very obese individual will have a upward compressive force related to the chest wall, a smaller lung in general, and that effect seems to not be something that we want to encourage. And yet, improvement in PaO2 relates inversely to proning's positional change in chest wall compliance. In other words, the worse the compliance becomes, the better the oxygenation becomes. This was shown by Paolo Pelosi a long time ago, and it presents a little bit of a conundrum. In ARDS, what happens? The PaO2 improves when the chest wall becomes stiffer due to proning, and proning will stiffen the chest wall. This is another Italian study from Davide Chiumello and colleagues, where they looked at the supine and prone without support features and looked at the pressures that are involved. And the pressures that are involved in the prone position are in the range of 11 centimeters of water on the belly, whereas in the supine position, it's only 0 centimeters of water. So there's about 11 centimeters of water pressure change as we move to the horizontal prone position. So the question is, if stiffening the chest wall is a good thing in ARDS, should we stiffen the chest wall and yet use the supine position? And this is an old image, and it's been tried many times. I say it's an old story because people have tried this technique before. And actually, Luciano Gattinoni, who should have been here, but unfortunately could not be here at the meeting, he once told me, we tried this once and it doesn't work, but this is an old story. If we look at abdominal weighting instead of chest wall weighting, it usually has neutral or adverse effects in some ARDS patients. I don't want to go in detail in this slide, but basically the plateau pressure does not improve whether you're at a low level of PEEP or a high level of PEEP when you place a 5 kilogram weight on the belly. This was done in Brazil by Carmen Barbas, one of the colleagues of Marcelo Amato. And in patients without COVID-19 ARDS, the weighting seemed to reduce the FRC, and compliance seemed to get a little bit worse or stay neutral of the total respiratory system, and it probably promoted collapse because the lung volume was smaller at 2 PEEP levels. But in COVID-19 ARDS, and I have taken a lot of heat for saying this at an early time, COVID-19 ARDS is not your typical ARDS. Unfamiliar mechanics occur in some late stage or severe ARDS patients. If we push on the belly, not just 1 cycle, but for about 10 seconds, we can elicit a response that's quite paradoxical, or what we think is paradoxical. And this was one of the first papers, paradoxically improved respiratory compliance with abdominal compression in COVID-19 patients. It doesn't make the whole system stiffer, it makes it less stiff. Even though the chest wall is getting stiffer, the whole system seems to be better. And another beautiful example of this was shown by Carteau and colleagues from France about the same time. Now, these are not small effects. In our patients, we had the plateau pressure on the left-hand panel and the respiratory system compliance on the right-hand panel. And you notice that as we do this, what we call manual belly push, we drop the plateau pressure, we improve the driving pressure, and we improve the respiratory system compliance. Not every patient will do this, but many will, especially those with late stage and severe COVID-19. And this is an image from a summary that Luciano and I put together. Here's a patient with a plateau pressure of 40 centimeters of water before pushing. We pushed on the belly, and the plateau pressure dropped to 28, and immediately on release, it recovered to its original high level of plateau pressure. Now I ask you, what is the most common thing we do at the bedside to try to protect the lungs? And that's to look at the driving pressure and the plateau pressure. And here we're stiffening the system and making them both drop. That's pretty amazing. It's a paradoxical effect. And you can reproduce that effect in many patients with either sternal pushes or with belly pushes. We tend to like the belly push. We probably change the distribution of lung volume in terms of absolute lung volume, whether we do a sternal push or an intra-abdominal push. But these are things that are still in investigation in our area. In both cases, the FRC is actually falling, but the whole system seems to be better when we measure driving pressure or tidal compliance. Now, sternal weights redistribute tidal volume and perfusion, and possibly over time will risk eventual dependent collapse of the dependent units. This is a very nice study by Rosegli and colleagues in chest in 2021 that does show that there's redistribution of tidal volume and perfusion when we sustain a weight, like putting on a heavy weight on the sternum, for example. The potential mechanisms for this paradoxical improvement by chest wall loading are basically two. We may recruit and improve ventilation perfusion matching by redistribution of regional transpulmonary pressures. We might be able to open collapsed zones preferentially and reduce dead space. But the other thing that's almost certain to be a part of it is the relief of end tidal over distension. Now, I don't mean to be too schematic here, but if we look at expiration on the bottom set of panels and inspiration as a patient gets worse, many lung units to take the capacity, diminishing to smaller number to a very severe stage, you may not find at end expiration that there's any change in hyperinflation. But if you keep the tidal volume the same, the end inspiratory strain of the baby lung units will increase with advancing injury. The point here is that it's not so much collapse anymore that we're worried about in these severe patients, it's the end tidal hyperinflation. Now that seems almost like heresy to some folks, but we're over-distending at the end of inspiration, and we're putting stretch on the lung and redistributing blood flows as well, as we look to a more severe patient with fewer and fewer lung units to take the tidal volume that we're pushing in. And if you want to schematically look at this, if you look at the blue lines, the chest wall and the normal lung, this is very familiar. Normally, we have those in opposition to one another, and under passive conditions, they balance out. If we then load the chest wall definitely stiffens, and the FRC falls, but we move from a position where the blue dots are in a non-compliant range in the lung to when the chest wall is loaded, the same tidal volume will operate in a better, more compliant zone for the CARDS lung or a severe ARDS lung. So what's the implications of this paradoxical response? Well, I can do it at the bedside in any patient in a very short period of time. The belly push is a diagnostic maneuver that likely implies end tidal hyperinflation is an important phase to consider. And it suggests that, hey, I better find a way to reduce the end inspiratory volume by using less PEEP, a lower tidal volume, or even a flatter, less upright body position. Oh my goodness, that's heresy as well. You don't want to do that. You don't want to put them flat. You want to have them upright. Well, maybe not. And if we follow lung protection guidelines and tables, they may need to be re-examined and revised if we take into account that there are these paradoxical effects in many very severely ill patients. Other therapeutic possibilities related to the belly push include an abdominal wrap of one type or another, or even a sternal compression vest. I advise you to read this paper. I only recently came across it. It's only a single case report, but it was done at a fairly early time, and my hat is off to these investigators who looked very carefully. They applied a lower abdominal compression in a semi-recumbent individual and observed a drastically decrease of his plateau pressure from 41 to 24 centimeters of water. The pulmonary compliance of 26 ml per centimeter of water, returning to the previous value as soon as it was released. They also did radiographic studies, and they found no change in ventilation distribution. This patient survived. Now, another question you might ask in the theme of proning is, does further compression also help compliance in the prone position? Oh, come on, really? Yes, it does. And we did this as well. Firas al-Mufti and one of my colleagues at the University of Minnesota did what we call a dorsal push, analogous to the belly push in the supine position. And yes, it did improve things. Now, those of us who have been classically trained know that position is a very important influence on FRC. And if we think of going to the horizontal position, it's actually a loading condition. And if we sit the patient up, it's an unloading position. But loading may be beneficial. So is it a good thing to try to go horizontal in these patients? And we think it is in certain patients. In a normal, healthy individual, it's a good thing to expand the lung, reduce the tendency for atelectasis to form, and in mild ARDS, we may recruit the patient. But in severe and late-stage ARDS, we have minimal recruitment going on, but a lot of overdistension, and that's when we get the paradoxical effect. And this is the paper that we documented showing this. This is John Seligman and one of my colleagues. We looked at the supine position in the standard 30-degree position, and then lifting the bed by another 15 degrees, and in the horizontal prone position, and lifting the whole bed without bending the legs or anything like that by 15 degrees. And what I want you to concentrate on is the driving pressures here. In the baseline condition, driving pressure is 13.9. We did a belly push and it dropped to 12.1. We then lifted the bed and took off the belly push and found that it went up to 16.7. And if we belly pushed again in that situation, we found that it fell again, the driving pressure fell down to 11.7. That was true whether it was in the supine position or in the prone position. And I don't want to go into too much detail here, but the point is it's a good diagnostic maneuver, and the possibility that changing the position of the patient, make them more horizontal, is a form of loading that we ought to quickly do in many patients, just to be sure that we're testing our original assumptions. Now, we can improve lung compliance by external compression of the chest wall, and there are many outstanding questions which I'm not going to go through in detail. How do you do it? How long? How much pressure? How do you standardize it? What's more important? And what's happening to gas exchange over time? Is it a long duration effect or is it a short duration effect? The bottom line that we found, and some others have reported it as well, is that the gas exchange actually improves, probably because you're reducing this hyperinflation, the end-tidal hyperinflation and redirection of blood flow. The ventilation improves slightly. The oxygenation does not deteriorate and may even improve. And the duration of it I'm not sure of, but I'll be glad to answer any questions that you have on that. So patients with severe ARDS may experience end inspiratory overdistension even when lung-protected and auto-PEEP is not detected. A simple bedside diagnostic maneuver, the sustained belly push, may reveal its presence. Dorsal compression may be an equivalent maneuver when prone. Interventions to reduce lung volume and to test for end inspiratory hyperinflation, reduce PEEP tidal volume, and assume a less upright position. And I emphasize the efficacy and safety of sustained chest compression have not been confirmed in all settings, whether you're using weights, binders, or pressurized vests. And I thank you for your attention.